Welcome everyone. In this video, we will be discussing Applanation tonometry, principle, technique and calibration. Applanation tonometry was introduced by Goldman, which is based on Imbert-Fick Law, which states that the pressure inside an ideal sphere P is equal to force W required to flatten area A. P can be determined if force F is fixed or area A is fixed. Ideal sphere is dry, thin-walled and flexible, but cornea is not an ideal sphere. Cornea being aspherical, wet and slightly inflexible fails to follow the law. Moisture creates surface tension S for the tonometer head. Lack of flexibility requires force to bend the cornea B, which is independent of internal pressure. The outer area of corneal flattening A differs from the inner area of flattening A1, which is of more importance. This diagram illustrates additional forces S and B coming into play in an aspheric cornea. Also, outer area A is different from inner area A1, so a modified version of Imbert-Fick's law was derived. Modified Imbert-Fick Law. When area A1 is 7.35 mm square, surface tension S balances the force required to bend the cornea B. This internal area of applanation is achieved when diameter of external area of corneal applanation is around 3.06 mm. Grams of force applied to flatten 3.06 mm diameter of the cornea multiplied by 10 is directly converted to millimeter of mercury. Different types of applanation tonometers used are Goldman applanation tonometer, Perkins applanation tonometer, pneumatic tonometer, pulse air tonometer, and tonopen. Goldman applanation tonometer, most popular and accurate tonometer. It consists of double prism mounted on slit lamp. The prism applanates the cornea in an area of 3.06 mm diameter. Before measuring intraocular pressure, the white marker point on tonometer head should be aligned with 0 mark on the measuring prism. Calibrated dial of the tonometer should be set at 10 mm of mercury with slit lamp magnification at 10x. After instilling topical anesthetic and staining with fluorescein, patient is made to sit comfortably on slit lamp and corneal biprism is illuminated with cobalt blue filter. Biprism is then advanced till it touches the apex of cornea and viewing is done uniocularly by single ocular of the slit lamp. Two semicircles are seen on either side of horizontal meridian. Now the dialing knob is rotated so that inner edges of two semicircles just touch each other and reading on the dialing knob is noted and multiplied by 10 to record intraocular pressure. Potential errors of applanation tonometry. Patient related errors are patient having thin corneas, thick corneas, astigmatism, irregular cornea. Machine related errors are tonometer out of calibration, elevating the eyes, repeated tonometry, pressing on the eyelids or globe, squeezing of the eyelids, observer bias such as expectation and even numbers. This is a video showing calibration rod used for calibration of the tonometer. It has three dial positions 0, 2 and 6 as shown in video, which correspond to 0, 20 and 60 mm of mercury pressure. This is a video showing technique of calibration. Calibration rod is inserted in the holder at dial position 0. At dial position 0, the feeler arm should be in free movement. If the dial is turned backwards, the arm should fall towards examiner. If the dial is turned forwards, the arm should fall towards patient. If the arm doesn't respond in the above way, the tonometer is inaccurate at dial position 0. Special conditions in which Applanation tonometry is not possible are corneal astigmatism, corneal edema, corneal scars, flat AC, and contact lenses. Corneal astigmatism. In corneal astigmatism, Myers are unequal. Underestimating the IOP is seen with the rule astigmatism, whereas overestimating the IOP is seen in against the rule astigmatism. For every 4 diopter of astigmatism, there is increase in 1 millimeter of mercury. In irregular astigmatism, the applanation tonometry is unpredictable. Recommended is a tonopen which uses Mackey-Merck principle. Corneal edema. In cornea with epithelial stromal edema, it is easier to indent. Hence, underestimation by 10 to 30 millimeter of mercury is possible. So, recommend Mackey-Merck T tonometer. Corneal scars. In corneal scars, there is increased corneal rigidity in the area of scar. So, increased IOP is measured. Recommendation is Mackey-Merck T tonometer or a pneumotonometer. Flat anterior chamber. With Applanation tonometry, it is unreliable with errors up to 50 millimeter of mercury. Flat AC after post trap can be due to oval filtration, which can record a low intraocular pressure, or aqueous misdirection, which can have a high intraocular pressure. Diagnosis is difficult with tonometer due to unreliability. So recommendation is digital pressure. Contact lens. In contact lens applanation tonometer is unreliable, so the recommendation is a pneumotonometer or a Mackey-Merck T principle included tonopen.